The final talk this session comes from Brinda Shukla, who's at University of Alabama. Thank you.
Good afternoon, everyone. My name is Brinda Shukla. I am about to start my first year of medical school, and I'm very excited to be presenting for you all today. My topic is on the use of Pegylated Interferon-Alpha in a case of Erdheim-Chester disease with congestive heart failure. And I have no financial disclosures to report. So as we are all familiar with, there have been many significant advancements in treatment for ECD, evolving from immunotherapies and traditional chemotherapies to the use of targeted therapies. The emergence of targeted therapies have revolutionized care, so much so that both the ECD consensus guidelines and the NCCN recommend the use of these treatments as the preferred first-line options. This table is pulled directly from the NCCN, which highlights targeted therapies such as vemurafenib and cobimetinib as the preferred treatment regimens in the management of Erdheim-Chester disease. However, there are also these conventional agents or non-targeted treatments that were previously being used frontline in the management of ECD. However, its use in the modern management of ECD in this current treatment era is unclear. This leads us to our examination of a clinical case of ECD who underwent 4 different treatments in less than a year time span. So here we report the case of a 55-year-old Caucasian male with a past medical history of colon cancer. So about 20 years ago, he had presenting symptoms of dysarthria and ataxia, with imaging showing multiple lesions involving the brainstem, cerebellar, and frontal lobe regions. And at the time, this was called as multiple sclerosis, which was given as his diagnosis. He underwent many years of various MS therapies with progressive disease and poor clinical functioning, along with the development of emotional lability and dysphagia symptoms. He eventually underwent a brain biopsy, which was called as lymphohistiocyte infiltration. He eventually saw a neurologist at a histiocytosis referral center who suspected that this could be Erdheim-Chester disease. They performed a thorough clinical evaluation along with a comprehensive skin exam, which revealed a skin nodule on the thigh. Punch biopsy of this thigh lesion showed xanthogranulomatous infiltrates, therefore the diagnosis of Erdheim-Chester disease was made. And the neurologist on the case additionally suspected that the MS could have been a misdiagnosis, and this was the progression of the ECD all along. NGS of the tissue biopsy showed the presence of Notch1, Notch2, and TET2 mutations with BRAF V600E negativity. A full-body PET-CT scan was performed that revealed no bony manifestations and only with CNS involvement. Our patient was then started on MEK inhibitor as frontline treatment. Now, before discussing into our case further, I wanted to provide a brief background on MEK inhibitors. So a notable advancement that transformed the current treatment era on histiocytic neoplasms is this phase 2 clinical trial describing MEK inhibitor efficacy. This trial showed an overall response rate of 89% in an 18-patient cohort. Another important takeaway from this trial is that many patients are not able to tolerate the full dose of the MEK inhibitor, as 56% of patients in this cohort had to have doses reduced due to side effects. And common adverse events that were reported in the group that led to dose reductions were decreased ejection fraction, rash, diarrhea, and fatigue and thrombocytopenia. Now, transitioning back to our case, our patient was started on cobimetinib, but almost immediately was then switched to trametinib due to an offered patient assistance program that reduced the financial cost of the trametinib. 3 months on treatment, imaging showed partial response to all of the brain lesions. However, 2 months later, he developed adverse events of dyspnea and edema. Given these adverse events, an echocardiogram was performed that revealed a decreased left ventricular ejection fraction of 25% and the presence of a left bundle branch block. This was classified as grade 2 congestive heart failure, and the MEK inhibitor was not pursued further. The next treatment option that was administered was intra-arterial melphalan. So intra-arterial melphalan showcases an innovative use of chemotherapy with demonstrated efficacy in histiocytic neoplasms, as first demonstrated by this 3-patient single institution case series. Results in this cohort were shown that the treatment was well tolerated, as there were no reported procedural adverse events, and in addition, the treatment was effective in reducing the overall tumor burden and in improving overall presenting symptoms. There have also been other published abstracts, such as one published in 2023, looking at the efficacy of intra-arterial melphalan in a cohort of 17 patients. 12 patients were said to have tumorous involvement of disease and 5 with neurologic involvement. Of these 12 patients, there was an observed radiographic response rate of 75%. In patients with neurologic involvement, this treatment was particularly effective in improving symptoms of dysarthria and ataxia. This treatment was as well tolerated, as there were no reported procedural events, and side effects after treatment administration were reported of 1 case of neutropenia and 1 case of melphalan hypersensitivity. Therefore, these 2 studies concluded that intra-arterial melphalan is an effective treatment, especially in cases of histiocytic neoplasms where there are no identifiable mutations to target, or if targeted therapies cannot be used due to a variety of reasons. So intra-arterial melphalan was chosen in the case of our patient with the goal of maximizing drug delivery directly to the tumor site, with the hopes of minimization of other systemic side effects, hence minimal impact to the congestive heart failure aspect that is complicating our case. After 1 single dose of the melphalan, however, our patient experienced a grade 3 adverse event of vision loss transient with an orbital migraine. The vision loss resolved a couple hours after the single dose was administered, and this treatment was not pursued further. Subsequent MRI that was performed 2 months later showed progressive disease with the presence of a more conspicuous abnormal pontine lesion. Now, given that both the MEK inhibitors and intra-arterial melphalan were not tolerated, our next treatment approach was subcutaneous pegylated interferon-alpha. So historically, interferon was used as frontline therapy in the management of ECD. However, the use declined due to the presence of intolerable side effects and variable response rates ranging from 50 to 80%. This table highlights a comparative overview of 2 essential studies looking at the long-term use of high-dose interferon alpha in large cohorts of patients. Just at a glance overall, the variances in response rates can be observed, especially in particular in those with CNS involvement. Focusing on this study that was published in 2012, results concluded that interferon alpha, along with the pegylated forms, were effective forms of treatment, but in particular, these treatments were effective in cases of severe ECD, such as those with CNS and cardiac involvement. Another conclusion from this study was that response rates were observed to be slow but improving, thereby suggesting that the treatment course may need to be prolonged in order to sustain optimal results. Now, focusing on this 2019 study, in addition, it highlighted that interferon alpha was an effective treatment used long-term, but the most important point from this study is that interferon is a significant cost-effective option compared to MEK inhibitors. Now, going back to our case again, our patient was started on subcutaneous pegylated interferon alpha, or Pegasus, as 4th-line treatment. At 5 months, there was an observed radiographic response of a persistent partial response. This treatment is also being well tolerated by our patient, as there are no reported no reported adverse events, and especially noticeable clinical improvement in terms of his speech, balance, and mood. And he is currently being monitored on this treatment. Another important point to consider when making treatment decisions is the cost of treatment. So here this table shows several treatments that are used in the management of Erdheim-Chester disease, along with its corresponding estimated monthly supply cost in the context of US dollars. At a glance, it can be seen that the conventional agents, such as Pegasus and IV cladribine, are significantly more cost-effective options compared to the MEK inhibitors. Therefore, in resource-limited settings, conventional agents may be the better preferred first-line option than MEK inhibitors. So in conclusion, we were able to learn a lot from our particular case of CNS Erdheim-Chester disease. Our first takeaway is that when complex and worsening neurological symptoms are present and a histiocytic neoplasm is suspected, thorough clinical evaluation should always be performed. In our case, comprehensive skin exam is what led to the correct diagnosis being made. Second, targeted therapies and other novel treatments, though with proven efficacy in histiocytic neoplasms, can oftentimes come with side effects that are intolerable and can pose significant financial barriers. And lastly, in cases where targeted treatments or novel therapies cannot be used due to a variety of reasons, immunotherapies such as interferon-alpha, along with its pegylated forms, are effective forms of treatment and should not be disregarded completely as treatment options. Here are all my acknowledgements, especially wanting to acknowledge my mentor, Dr. Goyle. Thank you all so much for listening, and I'm open for any questions or comments.